Welcome to the Doctor Family Podcast with me, Dr. David Stokes. In this episode, I catch up with a friend of mine from university over a Zoom internet connection, so please forgive the less than studio quality sound. Dr. Tom Fardon is a respiratory consultant at NHS Tayside and an honorary reader at the University of Dundee. He's been working at the sharp end of the COVID-19 pandemic. Please listen in to learn some more of the insights he's gained from working with these patients and, indeed, having caught the virus himself and recovered. Welcome, Tom. Hello.
Hi, how are you?
I'm very well. It's been a long time since we've seen each other.
Yeah, I was just thinking, when's the last time we saw each other in person? Must be 2001 or something like that. It's a long time ago.
It is a long time ago, absolutely. You're now up in Scotland as a leading respiratory physician, and we've also seen that, or a lot of people may have seen that you've been writing some very informative posts on Facebook, really sort of cutting through a lot of the misinformation which is out there, which has been very interesting to read. And I thought it would be great to pick your brains a little bit today about your experiences with COVID.
Yeah, no problem. The Facebook stuff started off because I think right at the beginning of this, there was so much information and what everyone now refers to as fake news. And I think people are getting really panicky about what to believe, what not to believe. And I just wrote a couple of posts to my very small friend list on Facebook of 30 or 40 people. And then it became evident very quickly that people were very interested. And now I have a frightening number of people following me on Facebook, and they're approaching 10,000, which is a weird situation to be in, but people do seem to appreciate some level-headed advice and opinion.
No, it's great. It's somewhat ironic that your posts have gone viral.
Yes, indeed, it is a bit strange.
So, I mean, you've been right there, in the thick of it, working on the COVID wards or ITU. Whereabouts have you been placing yourself?
So, so as a respiratory physician, we became sort of the front line in the COVID assessment unit very, very early on. In fact, I was looking back at my diary. I was on call the first weekend that we ran our COVID assessment unit. So we very rapidly converted our infectious diseases unit into a COVID assessment unit. And I worked that first weekend. Very challenging times, not knowing what the disease looked like, what people would present like, having to be assuming everyone has the disease and trying to get the test done and trying to manage people in a safe way. I still work on the COVID assessment unit, but I also work on our COVID HDU, so our high dependency unit, where people who are more sick than need to be on a normal ward. So that's where we're doing this CPAP treatment, which people may have heard of, which is the tight-fitting mask that blows air into the lungs to help ventilate people. So that's where you go if you're pretty sick, moderately sick, before going into intensive care to need a ventilator.
Okay, so obviously I think for most people, hopefully I understand you've had COVID yourself going through all of this. It's either a mild to a moderately nasty flu-like illness with upper respiratory tract symptoms and the usual flus, sort of fevers and myalgia. But obviously for some it is much more serious. What is the sort of presentation for those patients that are coming into you who are sicker?
So I think as you say, there's a really wide range of symptoms, and the data we've got from the European studies now show that there really is a massive wide range. But the majority of people who are sick enough to come to hospital and then need to be looked after have fever, breathlessness, and a persistent cough. Breathlessness on a short amount of exercise, so walking from here to the kitchen and back again, example, when you wouldn't normally be breathless, that's a prominent sign. We've noticed this slightly unusual thing that patients themselves often don't notice that they're breathless at rest. They're sat feeling okay, and it'll be their partner or their children or their friends who say, you're breathing very, very quickly, you look awfully breathless, and the patient says, I feel absolutely fine. That's a good trigger as well, that people who are breathing at 40 breaths a minute feel okay. We put the SATS probe on a finger and their saturations are very low, and those are the people who we need to look after in hospital. As you say, the majority of younger, fitter people are going to have a sore throat, a bit more breathless, headaches, flu-like symptoms, as you said. And most people tend to get over that for 4 or 5 days, and they're feeling pretty much back to normal by 7 days, back to work or back doing normal activities. Then there's people like me who sort of fall in the middle, where I got better after about 4 or 5 days, and then by day 7 I got a lot worse. And for that second week was much worse than the first week. So we just have to be a bit caution people that if they're feeling better at day 5 and 6, then just take an extra couple of days just to make sure that everything settles down. The people who are very, very sick and need high dependency care and intensive care do tend to be people who are older, in their 70s and 80s, people who have other illnesses, heart disease particularly, poorly controlled diabetes, and also people who are overweight. We now know that obesity is a real risk factor for doing badly with COVID. And those people can have a whole raft of different problems that start with the lungs and then can spread, like any severe illness, severe infection can spread to affecting other organs, the heart, the kidney, the brains. So by that point, it's pretty much like any other case we look after in high dependency and intensive care, looking after the whole person.
Okay, so it's interesting you talk about this second peak, as in terms of the illness. For some people, they get better and then they could get worse once more. Is that a secondary infection, do you think, or is there just a strange way the virus affects certain people?
We think it's this, I mean, you will have heard this phrase of cytokine storm, where what we think happens is because we don't really have any immunity to this at all, it's a brand new disease. So the way the immune system works takes about 5 or 6 days to build up antibodies and the right kind of cells to fight the infection. And then after about day 5 or 6, the immune system starts to work very aggressively and releases lots and lots of chemicals and hormones and things which activate the immune system hugely. And it's that overactivation of the immune system that makes you feel unwell on day 7, 8, 9, 10. So we don't think it's a secondary infection. We think it's just the way the immune system is fighting the infection away. And that in all likelihood, you're not infectious by that point, but you can feel pretty rough.
Yeah. Okay. So the immune system seems to be the thing that's causing the symptoms and the damage to the respiratory system, rather than viral damage itself to the cells of the respiratory tract.
I think so, and we're backed up with that with quite a lot of evidence from the far east. There's a very nice study in Taiwan where they did a lot of contact tracing and looking at how long people were shedding virus for. And the vast majority of people stopped being infectious at day 5, but the symptoms went on for much longer than that. So it's not the virus itself that's causing the problem. And I mean, you know, Dave, that a lot of symptoms we get for illnesses are not the primary effect of the bacteria or the virus. It's the immune system's effect that causes the symptoms like fever and headaches. And I think there's just an extreme version of that because this is a virus we've not come into contact with before. We see this in people who've got mild to moderate disease like I had, and we see it in people who've got severe disease. They come into hospital, we think they're getting better, we hang on by about day 6 or 7, then suddenly something happens where they get much, much sicker. So we do like to be very cautious with people who have been more unwell in HTU, particularly waiting for that day 6, 7, 8 deterioration. But it's interesting you talk about secondary infections because in the Spanish flu of 1918, yes, a lot of people died of flu, but more people died of secondary infection. 2 weeks after they had the flu, they got secondary bacterial infection in their lungs. And of course, in 1918, we didn't have antibiotics, so there was no treatment. And that's really what caused the millions of people to die. I was very worried, and I think I wasn't alone, that what we would see is people having COVID and then 2 to 3 weeks later come back with a bacterial infection. And thankfully, we've not seen that. We're 8 weeks in now, and we've not seen that second peak of bacterial infections. So that's really, really reassuring.
So, I mean, you mentioned that obviously a lot of the symptoms that talking about treating in primary care with simple paracetamol or what have you for the fever, are there any of the treatments that you've used in hospital for those sicker patients who are being affected potentially by this cytokine storm, their immune system going crazy?
So the bottom line here is that there's nothing yet that has been proven to be of any benefit. The cytokine storm story leads us to think about drugs like tocilizumab, which is an IL-6 inhibitor. So this is a drug which is widely available and used for people with rheumatoid arthritis. It reduces inflammation caused by this chemical IL-6. And we've measured in people with bad COVID at day 7 that their IL-6 levels are very, very high, off the chart. So it kind of makes sense to us that if you give the inhibitor, reduce those levels, then people might get better. But the data from the observational data from America, where they gave people tocilizumab on a compassionate basis, it did nothing at all. And in the people given the drug, they had to withdraw it because they had side effects. So tocilizumab doesn't work as yet.
Okay.
All the other drugs which you may read about in the news and are bounced around, nothing has been proven to be beneficial yet. Desminavir was shown not to work in the Chinese cohort. The Americans have told us that they have great data showing it does work, but then haven't published it. So you have to forgive my skepticism that, where it shows the data and we'll believe it. Calectra, the antiviral treatment for HIV, doesn't work. The hydroxychloroquine data is not great, I'm afraid. Everyone really hoped it would work, but it so far has not been demonstrated to do really anything. And in fact, in some of the graphs, it looks like people might do a little bit worse. There's the Diamox story, acetazolamide treatment for altitude sickness. Some people have said that the damage to the lungs is very much like altitude sickness, therefore use altitude sickness treatment. But there's a logical fallacy in there. Just because it looks like it doesn't mean to say it's working in that way. And indeed, we're not even doing a trial in Diamox because there's just no rationale for using it. So at the moment, the treatment for COVID is paracetamol for fever, analgesia for any aches and pains, and then treat the other things that go wrong, like oxygen, CPAP, support the kidneys.
I mean, with regard to the CPAP that you mentioned, and I know you've mentioned in your post as well on Facebook, for those who don't know, is where there's a tight-fitting mask fitted over the face. The patient is generally still conscious, and the machine is just puffing air into the lungs for them. That's what I understand.
Yeah, that's right.
Is that essentially because they're getting too tired to breathe completely for themselves, or what is the theory behind that? Is it keeping airways open? What's working in that case?
So it works in a number of ways. It certainly opens up airways, as you described. So people who've got collapsed bit of airway at the edge of their lungs, if you blow in there, it opens it up. It's just like blowing up a balloon. You get more lung opens up, so you get better gas transfer. And it certainly helps oxygenation. When you have COVID lung disease, so the chest X-ray looks bad and you've got lots of fluid floating around in the lungs become stiff and don't open properly. So by blowing air in, it opens up the lungs a bit more and allows more gas to be transferred, more oxygen to get in. So it's that stiffness. When we talk about lung compliance, and nice, young, healthy lungs are very compliant, blow in and out really easily, and unhealthy COVID lungs are very stiff. They lose that compliance. And that's what CPAP essentially does most effectively. CPAP works even better in people who are overweight. People who are overweight, when they lie down flat, the weight presses downwards, squishes the lungs up, and you end up taking small breaths. So CPAP helps open up the lungs even more. So no doubt there'll be some listeners out there who have CPAP at home all the time for their sleep apnea, and it's working in a very similar way. It's in fact exactly the same machines. When we're just using those machines with those masks for people in our HDU.
And that's that. I know at the beginning of the outbreak, everyone was concerned about the number of ventilators that were going to be available. Is there a limit on the CPAP capacity, or has that not been an issue either?
It's a great question. So much uncertainty at the beginning of this of how many people would be getting infected, how many people would need to come to hospital. So we modelled this across Scotland, and we thought that at the worst point of the pandemic, probably 500 people across Scotland would need to be on CPAP at any one time. So we put in orders for CPAP machines to make sure we'd have enough machines. In terms of population for Tayside, that would mean about 90 people, which is 3 wards, which in itself was a challenge to try to work out how we do that. But in the end, we never had more than 8 people on CPAP at once. So we managed to get, I think, 35 or 40 machines all ready to go, lined up, trained 150 nurses how to use them, and then we didn't need to use them, which is great.
Better safe than sorry.
Absolutely, but better forewarned is forearmed, and to have those machines ready was really important. And I know that in places of higher population density, so in London, Birmingham, Manchester, Leeds, etc., where there was a lot more pressure, a lot more patients, all coming at once, and numbers of ventilators were more challenging. But certainly in Scotland, we've been okay.
Okay, that's great. There's another question which a lot of my patients have been concerned about, and that's this seeming increased risk for patients of the black and minority ethnic groups, where there seems to be an increased risk of having a severe infection with COVID. Is there any evidence that you've looked at from that in terms of how accurate that is, how big the effect is, or indeed why that might be the case?
It's definitely a thing. I don't really have much personal experience because up in Tayside, we don't have a large black and minority ethnic population. So it's not really been a large issue to me to deal with personally. We have our immigrant population tends to be from Poland, Romania, Bulgaria, and they don't seem to do any worse than other Caucasian European people. But I do know that from the rest of it, mainly in England, absolutely, the black and the minority ethnic communities have been hit worse by this. There was some initial postulation that it was due to population density. I think it's reasonable to say that people from the Indian subcontinent, the culture is to families live together through multiple generations, and it's not uncommon to find great-grandma, grandma, parents, and children living together. So it was postulated that it was contact with many people which caused the problem, but that doesn't seem to be the case because it doesn't seem to discriminate particularly in terms of that. There was some suggestion that people from BME backgrounds would be from a lower socioeconomic group, but again, that doesn't seem to bear out either. There have been BME doctors and nurses, lawyers, business people who've had COVID and done worse. It's probably a genetic factor. It's probably to do with their ACE receptors, the receptor which the virus attacks and gets into cells. We know that that black people particularly, their ACE receptors are different, so we treat their hypertension differently with ACE inhibitors, etc. We haven't proven that yet. There is a study that's been led by a team in Edinburgh. It's a UK-wide study looking at the genomics of people with COVID. So that includes all comers to try to sample blood, extract DNA and look for common genes to see if there is a genetic linkage to doing worse. And whether that is a BME specific thing or not, hopefully we'll find out.
I think that was interesting. I'd thought about the ACE inhibitor idea before with initially, I think early on in the outbreak, people being concerned about people being on an ACE inhibitor and that turning out not to be such a concern.
Yeah, and actually some of the data from America is that being on an ACE inhibitor is protective against a poor outcome in COVID, which is very interesting and very hard to explain. The thing, they were able to show that things that lead to a poor outcome, definitely having ischemic heart disease and heart failure, hypertension if it's not very well controlled, diabetes if it's not very well controlled, smoking, but protective was being on an ACE inhibitor. Very unusual.
Absolutely. I mean, the other one that I have heard, which again has, I guess, a degree of plausibility, but no evidence that I've seen, is the vitamin D levels, where on average vitamin D levels seem to be lower in that group.
Yeah, and that's well known. Obviously, again, like you, I don't think I've seen any compelling evidence for it. There were some centres down in London who were sort of pragmatically deciding to give people vitamin D on the basis of what harm could it do, but actually having too much vitamin D can be bad for you and can suppress your immune system. And giving vitamin C, vitamin D, etc., it doesn't work for any other infection. I think this is an interesting topic, actually, that there's such a willingness, a desire to find a treatment here, that we're trying lots and lots and lots of different things. But if you take one step back and think, well, it doesn't work for anything else, why would it work for this? If it doesn't work for the common cold or doesn't work for normal coronavirus, why would it work for this virus? So I'm not saying it's bad that we're trying lots of things, and we absolutely should, but there needs to be a rationale. There needs to be what is most likely to work? What is our hit list? What's the first thing to do, second thing? Which is why the Diamox, the acetazolamide, we're not even researching it because there's just no rationale for it. So I think rushing around deciding to take massive doses of vitamin D, if your vitamin D level is normal, it's probably not going to do anything. No,
although I have to say from experience, whenever I test someone's vitamin D, I'm expecting it to be low in this country unless they're being treated. Yeah. Another question and a lot of fear that some of my colleagues have expressed is the infectious dose and your exposure to virus particles. So there was a real concern that medical staff and key workers were getting sicker potentially as a result of having a bigger infectious dose in the first instance. I don't know if anything has sort of borne out from that you've come across.
No, and I think it's important to distinguish between the two terms which are often conflated, which is viral load and the exposure dose. So viral load does seem to link with more severe illness. That came out of China very early, and that just makes sense. The more virus you have floating around in your bloodstream, the more likely you are to have severe illness, and that kind of makes sense. But there is no direct correlation between being exposed to a vast number of viruses in the air and having a very high viral load. There is a minimal infecting number, so it's unlikely that one virus, and I mean literally one virus particle, is going to cause infection. It's likely to be more like thousands. We don't know what that number is, and every infection has a different minimal infective dose, and we don't know what it is yet. I mean, it makes sense that if you're in an environment with lots and lots of virus, you're more likely to get it, and that bears out with where have been outbreaks that have been documented: churches, family gatherings, tight spaces. You're far less likely to be infected if you're in the open air, for example. But in terms of your question is about healthcare workers. Now, all the time that I've been working in a COVID positive area, I've had PPE to wear, and I've been and followed the instructions from Public Health England and Health Protection Scotland of wearing the right PPE and doing hand hygiene. And actually, I've always felt well protected. There is this argument that if you're wandering around and in a confined space with no protection at all, in a low-risk environment, how does that compare with being in a high-risk environment but with full PPE on?
Yeah.
And it's going to take some time to tease all that out. But I think so long as you do have the right PPE and it works, which in my experience it has done, then certainly my hospital, any hospital I've seen on the news or around the place, has good precautions in place, good airflow, good PPE, and for every patient that we see, we've got the right equipment, good hygiene afterwards, risks are minimized as much as possible. We just try to keep the message clear. It's a droplet thing. Use droplet precautions. Hand hygiene is probably the single most important thing out of everything. Social distancing, stay safe.
So, yes, not to get into the somewhat confusing recent messaging change from the government. Just talking about...
Yeah.
No, not up there. Yeah. Apologies, of course. Very different. The testing which is going on for COVID, obviously... the only test that I'm aware of for an acute infection sort of in the early days would be looking for the RNA, the genetic material of the virus itself. Doing blood testing for antibodies is only going to be useful after 5 to 7 days, I suspect, of having an infection. What's your experience of the testing? How specific and sensitive is it in the tests you're using and seeing?
So... it's another impossible question, or at least an impossible answer. There has been this worry all the time, all the way through this, about what's the false negative rate of the tests. How many people have a swab that says it's negative, but actually they have the disease? As you well know, Dave, every test, there is no test that's 100% sensitive. There's always going to be a false negative here or there. And working out how accurate it is, how many false negatives there are, is really challenging when there's no gold standard test to compare it against. So I can, if I have a gold standard test which is 99% sensitive, I can compare anything else against it, but I don't have that.
I mean, the thought that came to me is that you're obviously admitting patients who have got symptoms and signs of COVID. Are you finding that many of those are coming back with an initial negative test, and then you're finding subsequently they turn positive on retesting? Or
so that has happened a few times, and by that I mean fewer than 10, but more than 5. So we've had a number of patients, maybe 5 to 10 patients who we've thought, I really think they've got COVID. Their presentation seems like it. They're sick enough. They've got the right X-ray. The swab comes back negative. So we've repeated it. And that repeat test has sometimes been positive, and we've had to stop and think, well, why was the first test negative? And then on a couple of occasions, we've done 3 tests. Now, this is not unusual in medicine, as you well know. That the pre-test probability is really important. If the clinical suspicion is very, very high, the test is a confirmatory thing. And if that test comes back negative, we don't just stop and say, oh, fine, I was wrong. You take stock and think, well, actually, the probability is still very, very high that there's something here. Let's redo the test. Let's still It's that balance of probability, the art of medicine that you and I have been doing for 20 years that we still do. So the test is obviously a critical thing, but when we think the test doesn't fit with a clinical scenario, then we repeat the test and still treat people as though they have been, that they do have it. So that certainly is part of the process that all of us are doing. I think that testing is quite dependent on who does the test. So you need to have someone who's well trained, because you have to get the swab all the way down and all right to the back. And so long as it gets right to the back and brings a tear to the eye, then you've probably got the right place. And by doing that, I think I'm confident in our testing process. I've had the test done. It made me cry, and I was sure it was from the right place, and my test was positive. The challenge, of course, is how many tests can you do a day? Can you do 300 tests, 3,000 tests, 30,000 tests? And the more tests we have the capacity to do, then we'll test more people.
Yeah, absolutely. It'll be interesting to see with the home testing quite how effective that is. I suspect it's quite difficult to stick the swab quite so far into the nose to get that tear coming to the eye.
Absolutely, and I think some swabs and tests that you can do at home are actually very good, and that self-swabbing for sexually transmitted infections, for example, is been shown to be very effective. In fact, in some cases, better to do a self-swab than a doctor swab. But for this, I have some concerns that it's just going to be a little tickle at the front of the nose and a little tickle around the teeth. But if you've got someone else in the house who can do it for you, if you've got a wife along to come and do the test, they're going to be a bit more aggressive. So I think we just be mindful of how good was the test.
Absolutely. So I suppose the other thing that everyone is waiting for really at this point is a vaccine as a way out of the lockdown and to bring back normality. Have you been following along with the research that's been going on in the search for a vaccine?
Peripherally, I mean, it's not really my field, but it certainly is something I'm interested in. And the British Society of Immunologists have been putting on some really, really interesting webcasts and podcasts to talk about the process of how you might go about making a vaccine. Vaccine manufacture is incredibly complicated, hugely complex. What do you make the vaccine to? Is it the spike protein, which is the protein that allows the virus to enter into cells? Do you make it to a different bit of protein around the cell? The spike protein seems to be the best candidate. Then when you're making that vaccine, you have to make sure, do the antibodies that we make against the spike protein, are they actually protective against the disease? Because they might not be. I mean, it's very likely that they are. You have to be confident that it is. And that requires testing. And some of that testing may require re-inoculation of people. And that's ethically quite a difficult thing to get your head around. The evidence is that reinfection doesn't happen. That people who've tested positive with a PCR swab 2 weeks, 3 weeks down the line, it's dead virus and it's just hanging on from the single infection. So there are some researchers who've been bold enough in their papers to say reinfection does not happen. That's very confident. And I think we're moving in that direction. But what we need is a reliable antibody test that's set to an antigen, which is we're confident the test works and that antibody is actually going to give you immunity. So back to the vaccine, do you make a vaccine which is just the protein? Or do you give a live bit of virus or an attenuated bit of virus, a dead bit of virus? All these strategies have been used for vaccines for decades. So all these questions remain unanswered. There are scientists around the world feverishly trying to come up with a vaccine. I think realistically, you're looking at 18 months.
Yes, absolutely. It's not a quick fix, although I know there's a lot of people working on it very hard.
Yeah, absolutely. And I think they're working on all the right sort of things, but you have to give them time to make it work in animal models, to test it in people, and then to mass produce it.
Could I ask a slightly different question? Obviously, the effect that COVID has had on all of healthcare, as well as the rest of society, has been vast. And routine work seems to have gone out of the window in preparation for managing these potentially very poorly patients. And obviously to reduce the potential exposure of patients, particularly the cohort that you'll be looking after in the respiratory clinics, who will be very sort of delicate, should we say, or more prone to getting a very severe infection or a bad outcome with COVID infection. How have you been managing your hospital's outpatient clinics?
So this is the return to new normal question. We're not going to go back to what we had before. I don't think hospitals are going to work the same ever again. The idea of bringing a lot of people who are frail, fragile, as you describe, into a waiting room where there's 25 of them traipsing in and out of one room, coughing and spluttering in a respiratory unit, is going to sound bonkers now, having had this kind of rapid viral spread. So what we've done across Scotland, and I'm sure it's happening in England as well, is look at digital solutions. So we've started doing video conference style clinic appointments. So everyone knows what Zoom is now, and everyone is using these video conferencing type systems to have meetings, speak to their friends and family, et cetera, et cetera. And we have a secure system, so it's not hackable in any way, and it coordinates well. So the patients get a letter. Here's the URL. Stick this in your phone, tablet, PC, Mac, whatever. And then you get put through to a virtual waiting room. The receptionist meets them as they would normally, has a wee chat. They wait in the waiting room, and then I come in and I have my consultation. It's actually very efficient. No travel time. I can do it from anywhere. There are some things I can't do. So I can't examine people. So there's going to be some limitation in that. I can't do tests, but there's ways around that. We can get people bits of equipment to measure saturations, etc., or blood pressure machines, etc. So we can, in respiratory medicine, actually, we can manage probably 80% of what we do through a virtual system. The remaining 20% of work, and a lot of this is more surgical work, where you have to examine the patient. You need to lay a hand on a tummy and have a feel, or you need to put a camera in a hole and have a look. That still needs to be done in face-to-face. And what we're looking at is clean pathways, or green pathways, as we call them. So how do you get people to have the confidence to come to a hospital where, yes, there are some people in one part of that hospital who have COVID, into a clean environment where there isn't any COVID, and people can come in and be reassured that everything's okay. And rather than sitting in a waiting room for 2 hours with another 20 people, you come in and you get seen. It's more efficient. You come in, get seen, and go out again. And just simple things like one way in, one way out, so you don't cross paths with people. These are logistic things which every hospital is now thinking about, so that people can have the confidence to come to hospital and feel safe.
Fabulous. I think we've seen that as well in general practice. This is forced through a number of changes. It'll be very interesting to see which of the changes are for the better and which we need to rethink once we're able to. So on that positive note, I'd just like to thank you very much for your time today. I wish you the best of luck in continuing your treatment of these patients, and I look forward to catching up with you again soon.
Yeah, maybe not another 19 years next time.
No, absolutely. Many thanks for listening to our podcast. Please get involved on our website and social media, linked in the podcast show notes. I also add links to the Facebook posts that Tom has been gaining such a following with. We would love to hear your feedback. If you enjoyed this show, please subscribe and tell your friends. I'd also like to thank Drew Worthley for allowing us to use his fabulous music in our intro. See you next time.
Che Guevara is on my coaster. He's wreathed in gold stars.